Pharmacokinetics. A 23-year-old man with bipolar disorder stabilized on lithium as an inpatient. He does well over the next months as an outpatient with stable lithium levels. Then one hot June day, he is brought to the ER with lithium toxicity. What's his most likely cause of the toxicity? Dehydration, doubling of lithium dose, low sodium diet, starting an ACE inhibitor, or starting an angiotensin II inhibitor. And the most likely one here is dehydration. This is a big deal, especially in high climates. Patients who are working out or just outside a lot, it's very hard to prevent them from ever getting dehydrated, and especially with like lithium, that in itself could be leading to a very dangerous situation. Now, all these other options will also very likely lead to increased lithium levels. Doubling of the lithium dose, well, that's obvious. A low sodium diet. So when a patient is stabilized on lithium, has a good therapeutic effect, very low, adverse drug reactions or effect, and they're stabilized in this way on that dose on the outpatient while they're outpatients. Let's say they are then hospitalized, perhaps on a medical unit, maybe even a psychiatric unit, and someone puts them on a low sodium diet. What then occurs is they can reabsorb lithium from the distal tubule of the kidney at higher rates. So, the kidney kind of treats sodium, the sodium ion and the lithium ion, as kind of equivalent. So when there's very low sodium to be reabsorbed, then the kidney is more able to reabsorb higher rates of the lithium and excrete less of it, and then that could lead to increased plasma levels. Starting an antihypertensive of different classes can lead to lower blood perfusion through the kidney, thus leading to lowered excretion rates. Pharmacokinetics is the looking at the movement, right? Kinetics, the movement of the drug through the body. Again, the body is trying to get rid of this thing as soon as possible. So when it's given, it's absorbed, it's then distributed, and then the body is very actively trying to get rid of it through elimination, which includes metabolism and excretion, as we'll go over. So ADME is our kind of mnemonic, ADME. So absorption, it's affected by the GI motility, gastric pH, chelate formation, bypass surgery, transport proteins. And I'll talk about transport proteins towards the end of this presentation. Distribution is affected by volume of distribution, plasma protein binding, and again, transport proteins. Metabolism, we divide that into phase 1 and phase 2 enzymes and what happens there, and we'll talk about that. And then excretion, most of it occurs through the kidney. Renal excretion and the metabolites or parent drug end up in the urine, or you can have hepatic excretion where it goes into the bile, into the GI, and into the feces, and again affected by the transport proteins. Let's look at absorption. So absorption is lower in GI disease because absorption is dependent on gastric acid secretion, bile salt formation, gastric emptying time, intestinal motility, and chelate formation. Now, absorption is affected by reduced gastric acid secretion in both directions. It may lead to greater or lesser absorption of that drug depending on the chemical nature of that drug. So, for example, reduced gastric acid secretion, meaning higher gastric pH, it increases the bioavailability of acid labile drugs like penicillin. However, it decreases bioavailability of weakly acidic drugs like phenobarbital. And also to note is there are drugs, very commonly used drugs, that will increase gastric pH, and they include the proton pump inhibitors, the H2 blockers, and those kind of like calcium-based antacids that chelate with the drug, that can chelate with the drug. So This is all, very complicated on which direction things go. So I don't think we need to know exactly which drug, is absorbed more or less based on the gastric pH. But what's very important for the exam is you have to know that anytime you read a vignette on the exam, every fact provided in that vignette treated as being very relevant to, figuring out what is going on, what's the problem, and then how do you assess it and how you might treat it. So if there's something mentioned about the patient, taking now proton pump inhibitor or is placed on an H2 block or whatever, or maybe it's even the patient's talking to you, a psychiatrist or other clinician, and is, popping antacids all the time, and all of a sudden they may be having, maybe increase of adverse drug reaction, and they're like, I didn't change it, nothing changed. Or maybe they're having less benefit, maybe now they're more depressed or anxious, and it's like, well, I didn't change anything, nothing really happened. But if something like that is mentioned about like GI disease or GI medications or anything like that, it's in a way there because it may lead you to be, or want you to think that there might be a change in the absorption. Further, absorption is going to be usually negatively affected by gastric bypass surgery. It certainly can lead to decreased drug absorption. It can also lead to increased alcohol absorption, which could be dangerous. It could lead to nutritional deficiencies, especially B12 and iron, even with supplementation. So that's important to know. Then when you have B12 deficiencies, especially if they're chronic, they can interfere with cognition and even lead to a dementing disorder. And then absorption is also affected by reduced bile salt formation, and that can decrease the bioavailability of lipophilic drugs, which are the majority of the drugs that we prescribe. Most psychotropics are lipophilic. Now let's look at distribution. So children on average have more total body water and less fat, and this is total body water, both intracellular and extracellular. So there's an increased volume of distribution of water-soluble drugs, for example, lithium. And so, a child may need kind of what you would regard as maybe higher than average doses of lithium if they were on lithium based on their weight or their size, just because they have a larger volume of distribution. Conversely, elderly people are kind of, on average, just the opposite. They tend to have less total body water and more fat. Now, when you have more adipose tissue, then there's going to be more adipose tissue, and if you're taking a lipid-soluble drug, that adipose tissue becomes like a sink, meaning it like absorbs, right? You have leaching in from the systemic circulation of that drug into the adipose space, right, into the adipose tissue. So what this does is that it can, at the beginning of treatment, lead to lower peak serum levels of the drug, and then also, and very dramatically, can extend the period of equilibration and really increase the elimination half-lives. So what happens with a lipophilic drug, it's being transported through the plasma. It's often highly protein bound. That's how it, kind of gets through the plasma without like clumping up or whatever. And then, but it's very likely to enter the adipose tissue. So at the beginning of treatment, there's no drug really on board. In the adipose tissue, there's hardly any of that drug. And so the leaching into the adipose tissue is much greater than the leaching back out from the adipose tissue. So that more, the drug just kind of keeps leaching the adipose tissue, and then it's not bioavailable, right? Because it's in that stored compartment. Now, after a period of some weeks, 2, 3, 4, 5 weeks, there's going to be equilibration. So then, there'll be just as much drug leaching into the adipose tissue as leaching back out. Now, what effect does this have in the real world? Well, especially with like older patients who may be cognitively susceptible or susceptible to side effects. And you give them medication, for example, like lorazepam. They're feeling anxious, whatever. Older, maybe they're overweight. And they might do very well. They might say, well, this is great, Dr. Jack, and they're good the first week, the second week. The first week, they're not feeling much. Second week, they're feeling good. Third week, they're still good. And then, fourth week, you get a call that the patient fell and their daughter is calling you like, hey, Dr. Jack, what happened here? And that's because it took that long for that drug to start equilibrating. So what's sometimes done, we wouldn't really do this very commonly, but like if you're a neurologist treating epilepsy, you might have to do like a loading dose at first with these lipophilic drugs, and then kind of a constant dose. So this is very important because this could lead to kind of severe adverse drug reactions that are several weeks, after the initial dosing, the start of that medication. On the other hand, because older people have less total body water, they may need much smaller lithium doses to reach therapeutic levels than you might imagine based on their weight. Now, decreased albumin, as can occur with malnutrition, can increase levels of free drug. Pregnancy, it increases maternal total body water dramatically. And then during and following delivery, much of that water is excreted. So, this is most relevant to lithium. So during a pregnancy, if you have the pregnant woman on being treated with lithium, and to maintain a therapeutic level, her dose may need to continue to be increased during the course of pregnancy until it kind of stabilizes maybe in the third trimester. And then what happens during delivery? Well, there's a lot of water, 30 or more percent of the water is being quickly excreted, and usually it'll take an equivalent amount of lithium with it. So it doesn't necessarily lead to, lithium toxicity, but it may because of some disequilibrium. So what was often done is then that woman has a planned delivery day. It's induced delivery, induced labor, and then the lithium dose of several days ahead of time is either decreased to half or even stopped temporarily until after delivery. The other reason that this is done is because in order to then not have the neonate, the baby after they're born still having all this lithium on board, because they may not be very good at eliminating it. What else? Oh yeah, so these psychotropic drugs that we prescribe, they cannot freely enter or exit the CNS due to the blood-brain barrier. Transporters are often involved, almost always to some degree. Now the more lipophilic drugs, some of them can actually pass through without the transporters, but again, it's kind of very, very dependent on the differences between those the chemicals, the drugs. But let's move on into metabolism now, and we begin with phase 1 modification. So in phase 1, there's going to be direct biotransformation of that substrate of the drug through a chemical reaction, through oxidation, reduction, or hydrolysis. Now the metabolite is often more water soluble than the parent drug on purpose. That's the reason for this biotransformation, in order to make it more easily excreted. However, phase 2 metabolism is often needed additionally for further excretion. So oftentimes the phase 1 metabolites will move through phase 2 metabolism. The metabolites' biological properties obviously are changed from the parent drug, but this is important to note that just because the parent drug is metabolized doesn't mean it becomes less bioactive. Now it is true, some of the metabolites may be completely non-bioactive. They could be partially bioactive, less than the parent drug. They may be even more or equally as bioactive. For example, fluoxetine, both the parent drug and one of its main metabolites, norfluoxetine, are both biologically active, are both SSRIs, right? Or it actually could be that the parent drug is not biologically active, and only through metabolism does it become biologically active, and that's what's called a prodrug, which we'll go over. Now, phase 1 metabolism is mostly done through the CYP450 enzymes that are primarily in the liver, but not only. And then other enzymes are also involved in phase 1 metabolism to a lesser degree, and they include the flavin-containing monooxygenases that are also found in the liver and also lung, kidney, and gut to some degree, and also the plasma esterases. Now, as I mentioned, most psychotropics go through phase 1 metabolism, and then the phase 1 metabolites either are excreted directly or go to phase 2 metabolism. The CYP450 enzyme system, it's a group of related liver enzymes. They get their name from when they were first isolated. They absorbed light their absorption was highest at the wavelength of 450 nanometers. These enzymes are also found in the brain and the gut, in addition to the hepatocytes in the liver. These are intracellular, right? They're on the endoplasmic reticulum. They metabolize most of the xenobiotics in phase 1 metabolism. They're categorized and named based on family number, subfamily letter, and then number. So, the ones that they're grouped according to similarity. So all the ones that are from the family 1, they're going to be more similar than the ones that are from family 2 or 3 or what have you. And then the subgroup, you're going to have the letter A, C. So even here we have 2C9 and 2C19. So these are like from the same family and the same subfamily, and then there are differ, in their specificity. They're different enzymes, but very similar to one another. And then all of the 2s, 2C9, 2C19, 2D6 are going to be more similar to each other than to 3A4 or 1A2. Each enzyme is a specific gene product with specific substrate drug specificity. So each of these is coded by a gene. Again, these genes are polymorphic. They differ between different human beings, and thus the enzymes, have different ability to metabolize, often quite dramatically different between people. Gut. Now, talking about the gut CYP450 enzyme inhibition and induction effects. So now we're not talking about the liver ones, but I just wanted to point out, because again, as I mentioned, the CYP450 enzymes are also not in other organs, including the gut. So for example, grapefruit inhibits gut CYP3A4, decreasing metabolism of certain drugs, increasing their plasma levels. So grapefruit works both at the liver level and at the gut level. So I think that's just kind of to kind of highlight that, this is more complex even than we can get into. But we don't need to know specifically all those details for the exam. I think I'm pretty much what I'm telling you, sharing with you, I think is pretty much the level that we do need to know for the exam. But please let me know if I'm wrong. I would certainly be very happy to correct and expand, or maybe some areas need less, perhaps, coverage. Now, the CYP450 enzymes obviously interact with the substrates, with the drugs and other chemicals, and they can be induced, they could be inhibited, or they could be saturated. So some drugs are inducers. They can induce some of the enzymes. So, for example, phenobarbital, cigarette smoke, cannabis smoke are inducers. St. John's wort is an inducer. Carbamazepine is an inducer. 3A4. Drugs can be inhibitors, meaning they inhibit the enzymes. They include fluoxetine, paroxetine, fluvoxamine, valproate, ketoconazole. Drugs can saturate the enzymes without being inhibitors or inducers. They just like if the patient's taking like a lot of this chemical, a high dose of drug, it may be enough to saturate that enzyme system through which that drug is being metabolized to the degree that, it slows down its metabolism, and then maybe of other drugs who are going through that same metabolic system, through that same isoenzyme. Polymorphisms, again, these different forms of these genes coding for the enzymes. This is what's studied in pharmacogenomics. And, as we all know, patients may be poor, normal, or extensive metabolizers. Other terms are used, rapid, ultra-rapid. And there's, just for example, and this is almost mind-boggling, at least it is for me, that the population variability in CYP3A4 activity and how effective that enzyme is in metabolizing the drugs that go through it is over 100-fold. That is just stunning. A good example to look at to kind of start understanding all of these interactions, complex interactions, is carbamazepine. So a drug, any drug, can alter levels of other drugs and can have its own levels altered by other drugs. So carbamazepine, right, it's a 3A4 inducer. It does decreases levels of itself. That's called autoinduction. So the level, if you checked it a week into starting the dose, the blood level might be higher than it is 2 weeks at week 2 since the start of treatment. And oftentimes you do have to track levels of carbamazepine and then occasionally increase the dose to maintain therapeutic levels. Carbamazepine is a 3A4 inducer, decreases levels of other drugs like valproate, haloperidol, oral contraceptive pill, and other meds like protease inhibitors, midazolam, and vincristine. And this is called heteroinduction. It's very important to note the oral contraceptive pill effect, because carbamazepine, as an inducer of it, can speed up its metabolism, lower its levels, lead to contraceptive failure, and then at the same time expose the fetus to the carbamazepine, and carbamazepine has teratogenic effects. Other drugs can induce 3A4, thus decreasing carbamazepine levels, and it includes like phenobarbital, phenytoin, rifampicin, St. John's wort, and some glucocorticoids. And then other drugs can inhibit 3A4, thus increasing carbamazepine levels, such as lumateperone, pimozide, ketoconazole, grapefruit, cannabidiol, erythromycin. Now those are all you should know, that all of those, remember those, underline them or highlight them, that they are 3A4 inhibitors, because all of those have been tested. Now there are other ones which are less important for us to know, but just so you know that there are many other ones. They include cimetidine, ritonavir, nifedipine, and verapamil. These isoenzymes, these metabolic enzymes, they mature at different, they mature over the lifetime, right? So when the neonate is born at birth, these isoenzymes are not very active. There's not very many of them. And therefore, if a mother is taking a drug and and then the mother is also metabolizing that drug does cross the placenta, so the fetus is exposed, but then it's the mother who's doing primarily the elimination of it through metabolism and excretion. But once the neonate is born, they have now the baby has a certain amount of that drug on board, and it itself can't really metabolize and excrete the drug, and may have kind of show some toxic effects from it, lower APGAR scores, some signs of distress. And then later on, as it slowly is eliminating that drug, it can also then show kind of discontinuation symptoms too. So that's the way that this is relevant to us as clinicians. We're not giving neonates meds, but this is what happens if we're the psychiatrist who is prescribing an antidepressant to the mother. We need to know what effect it will have on her fetus and newborn. Now, around the age of 2 or 3 years of age, these isoenzymes will kind of reach kind of the effectiveness that they would kind of show at a mature level, that teenagers and adults would have. And it actually overshoots and it becomes more effective. It can churn, metabolize medications and other chemicals at higher rates, partly due to high perfusion through the liver, and then also just because there's higher density of these enzymes in the hepatocytes. And then that's kind of true through childhood, and then around mid-adolescence, like age 15 or something, it kind of evens out at kind of like adult levels of metabolic activity. And then it's kind of maintained throughout adulthood and then really slowly declining into older age, again based on now lower perfusion and then lower density of these enzymes. Metabolism, now let's move on to phase 2, and this is conjugation. Conjugation means, right, the joining together of the drug together with an endogenous substrate. Now what are these endogenous substrates that the drug can be joined with or conjoined with? They are glucuronic acid, glutathione, sulfate, acetate. The glucuronides are excreted into the bile through the liver, and then the others through the kidney into the urine. Conjugation may occur directly or after phase 1 biotransformation. This conjugation makes the drug more hydrophilic and thus even easier to excrete. There are phase 2 inhibitors and inducers that exist just like with phase 1, but they have a lot less of this dramatic effect and drug levels. Inhibitors of phase 2 enzymes may only increase the drug level maybe by a factor of 2 rather than like a factor of 10, for example, compared to the phase 1 inhibitors. The only one we need to know really for the exam is valproate inhibits UGT1A4. UGT1A4. And this is the mechanism for increased levels of lamotrigine and or lumateperone with valproate. And that's why, very importantly, when a patient is on valproate, we want to give much lower doses of lamotrigine. Conversely, if a patient is already on lamotrigine and we want to add valproate, we want to first decrease the dose, or at the same time decrease the dose to half of the lamotrigine because of this inhibitory inhibition of the UGT1A4 by valproate. Very quickly, as I'm already alluded to, prodrugs. This is when the parent drug is not biologically active, but its metabolite is. Thus, when you inhibit metabolism of the prodrug, you actually reduce its levels of its bioactive metabolite. Now, the benefits of prodrugs are that it improves absorption and decreases fluctuations in its plasma levels. It takes advantage of the first-pass metabolism, which is like kind of like a scourge for many medications because most of it never reaches the systemic circulation when given orally. But here, it's actually the first pass is metabolizing the inactive parent drug into the biologically active metabolite. It tends to reduce adverse effects and improve site specificity. The only three we really need to know is lisdexamfetamine, used to treat binge eating disorder and ADHD. And it's a prodrug that is metabolized into its active metabolite, D-amphetamine. Codeine is metabolized into its active metabolite, morphine. And then oxcarbazepine is metabolized into lycarbazepine, or MHD. Also just note in passing that tamoxifen and L-Dopa are also prodrugs. Now, why are drugs susceptible to slowed metabolism, and which ones are they? Well, metabolic enzymes can become saturated or inhibited. If two or more drugs are metabolized by the same enzyme, metabolism can be slowed, even if neither drug or med is an inhibitor. Now, the fewer metabolic pathways that metabolize a drug, the more susceptible that drug is to drug-drug interactions. It only has like one or just very few paths to get metabolized. If they are inhibited or saturated, the blood levels of that drug can increase rather substantially. But if that drug can be metabolized by many different enzymes, then even if it's kind of certain enzymes are inhibited or saturated, that drug can be metabolized through other ones. So the antidepressants that are more affected by and affect other drugs by these metabolic drug-drug interactions include the tricyclics. They're metabolized primarily through 2D6, CYP2D6. Fluoxetine and paroxetine are very strong 2D6 inhibitors. So what they do is they can lead to increased levels of other drugs, like the tricyclics, including, could lead to levels that could be lethal. And also, it's important to note that both fluoxetine and paroxetine, they have nonlinear pharmacodynamic effects, pharmacokinetic effects, meaning like if you double the dose of those medications, their plasma levels may more than double, partly because they are inhibiting their own metabolism, and the more drug you give, the more effective it is in inhibiting its own metabolism. So fluoxetine, paroxetine can increase levels of other drugs and of themselves. And then fluvoxamine, inhibits many different of these metabolic enzymes, and then thus can affect other drugs, many other drugs. It itself is probably not that much susceptible because it is metabolized by several different isoenzymes, but it can have dramatic effects on other drugs, and we're gonna go over that too. Now, let me cover the term elimination, because people often ask me, what is elimination versus excretion? Well, elimination involves both metabolism and excretion. It's the sum of the processes of removal of a drug from the body. And then metabolism and excretion may both decrease 30 to 40% in the elderly. So if you think about, decrease of metabolism down to, 70%, 0.7, and then excretion down to 0.7, 30% decrease, you multiply 0.7 by 0.7 and you get 0.49. So, that right away would cut down elimination down to half. And then if it's like 40% and 40%, it would be even more dramatic. So these kind of changes that occur with age can be really quite dramatic because of the additive effects. Metabolism's role in elimination, well, hydrophobic drugs undergo biotransformation to become more hydrophilic, meaning more polar, and easier to excrete. And then first-pass metabolism is a mechanism of elimination, right? It's trying to prevent that chemical from entering the systemic circulation without kind of in its raw form. It's already being metabolized to try to make it more excretable. Excretion refers to the direct process of drug removal, occurs mostly through the kidney, but also through the liver, into the bile, into the gut, into the feces. Minor routes include lungs, breast milk, sweat, saliva, and tears. Renal excretion, it changes with age. There's around 1 to 2% loss of glomerular function a year. The filtration rate declines by about 35% from middle age to old age. And not only are there changes directly in the kidney, there are changes in the afferent and the arterial system, so there are changes in total perfusion through the kidney. And also there's development of these efferent arterial venous shunts. And the medications that are going to be most affected by renal disease and are often tested regarding this area is lithium and duloxetine. Transporters. Changing the function of a membrane transporter alters plasma concentrations, including through drug-drug interactions. So this is a very rich area of study. It's very complicated. There are a lot of different transporters in many different organs. So just very quickly, really just at the very surface level. So let's think about the transporters in the gut. When they are saturated or inhibited, then gut absorption from the gut lumen of the drug is slowed, decreasing its plasma levels, right? Because gut absorption is active. There are transporters that are absorbing the nutrients and other chemicals from the gut. Then there are transporters in the liver and kidney. When they are saturated or inhibited, the excretion of a drug is slowed, increasing its plasma levels. Influx and efflux transporters exist in the blood-brain barrier. Most xenobiotics do not freely cross the blood-brain barrier. There are influx transporters. When they are saturated or inhibited, transport of a drug into the CNS is slowed, decreasing its CNS plasma levels. And then efflux transporters, when they are saturated or inhibited, a drug's elimination from the CNS can be slowed, increasing its CNS plasma levels, because it's just kind of stuck in there. And I added this slide. I just want to kind of show you what is the blood-brain barrier. It really has three components. So if you look at the image, there's a black arrow that shows the capillary lumen, and then the first thing you see around it are these endothelial cells of the arteries and arterioles and capillaries, right? And there's tight junctions between them. So that's like one way that this blood-brain barrier is formed, through these tight junctions between the endothelial cells. Number two, then surrounding the endothelial cells, you have the basement layer, basement membrane. And then number three, you have these astrocytes that really surround the capillaries kind of throughout the entire distance of all the capillaries and the CNS as still another part of the barrier. So thank you very much. I appreciate your attention. I look forward to seeing you back for part 2 of the 3-part series. Take care. Signing off is Dr. Jack. Thank you.